are generally described as delays, deficits, impairments, or similar terminology that implies the need for remediation or a cure. As the spectrum has broadened over the 21st century to include an increasing number of individuals with intact language and cognition, many autistic individuals identify as being neurodiverse or neurodivergent and do not seek to be cured or viewed as disordered, but rather wish to be accepted and supported for their unique differences. Nevertheless, the label still implies that the individual is experiencing challenges, vulnerabilities, and in some cases, delays/deficits that negatively affect multiple areas in life. The authors of this book have tremendous respect for neurodiversity, as we do for every individual across the extremely diverse and complex spectrum, including those more severely affected. Thus, in our aim to help educate and train clinicians on how to effectively identify ASD based on behavioral symptoms, we strive to focus on the diagnostic label serving to enhance the quality of life and self-determination rather than to imply curing or fixing anybody. We will use terms such as symptoms, disorder, condition, and disability throughout the text, given that this terminology is still part of the diagnostic criteria and medical nomenclature to which clinicians are exposed. We will also use identity-first language, autistic individual, opposed to person-first language, individual with autism, to respect that not all individuals view ASD as something separate from who they are. The current diagnostic criteria for ASD put forth in the Diagnostic and Statistical Manual, 5th edition, text revision, DSM-5-TR, APA 2022, requires persistent symptoms in two broad areas. 1. The presence of delays/deficits/challenges in social communication and interaction in all three of the following areas, either currently or by developmental history. A. Social-emotional reciprocity. For example, shared interests, shared affect, and conversations. B. Nonverbal communication. For example, integrated eye contact and directed facial expressions. C. Use and understanding of gestures and body posture. And D. In developing, maintaining, and understanding relationships. For example, interactive imaginative play, interests in peers, and making friends. And 2. The presence of restricted, repetitive, or stereotyped behaviors that include at least two of the following four areas. A. Stereotypical motor movements or use of objects, for example, hand flapping, spinning, lining up toys, and repetitive or stereotyped speech. B. Insistence on sameness or routine, for example, difficulty with transitions, changes in routine, and rigidity in thinking. C. Highly restricted interests that become overly intense or all-consuming. For example, intense interests on topics and fixation on objects. And D. Sensory processing impairments. For example, hyper or hypo reactivity to sensory input or seeking out sensory input. This combination of social vulnerabilities and stereotyped behaviors must be present in early development, even if symptoms go undetected until adolescence or adulthood, and clinically impairing across multiple contexts in life. In addition to listing the diagnostic criteria for the two categories of social communication/interaction symptoms and restricted, repetitive, and stereotyped behaviors, the DSM-5 has 3 severity levels that clinicians need to apply to both categories. Level 1 is specified for individuals who require support at the lowest level. For example, symptoms interfere with functioning in one or more contexts, but they are mild. Level 2 is specified for those who require substantial support. For example, there are marked impairments that interfere across multiple contexts. And Level 3 is specified for those who require very substantial support.